Hi, my name's Bridget Nelson. I'm actually a PGY1 resident at the VA in Milwaukee, and I love it there. I'm actually here to introduce some people that I worked with previously during my pharmacy rotations as a student at MCW. This session is going to be available for continuing education credit for pharmacist learners and is titled Vax to the Future, Navigating New Pediatric Immunization Recommendations. We've got Dr. Jesse Kramer and Dr. Kayla Hebner, and they'll guide us through the updated guidelines. Jesse Kramer is the manager of clinical pharmacy services at Children's Wisconsin and is an assistant clinical professor in the Department of Clinical Sciences at the Medical College of Wisconsin School of Pharmacy. Jesse has also authored multiple original peer-reviewed pediatric focused research articles in various academic journals. We've got Kayla Hebner, and she is a pediatric clinical pharmacist at Children's Wisconsin in Milwaukee. She's received her doctorate of pharmacy degree at the UW-Madison School of Pharmacy. She completed her PGY1 pharmacy residency at the University of Tennessee, Le Bonheur Children's Hospital in Memphis, and a PGY2 pediatric pharmacy residency at Children's Minnesota in Minneapolis. Currently, Kayla staffs various clinical areas, including general pediatrics, emergency medicine, pharmacokinetics, and the operating room. Additional information for this session and about each of our speakers can be found on the PSW conference app. So please help me welcome our awesome speakers today.
So Jesse and I have no financial relationships to discuss. And we just wanted to mention that we will be discussing off-label use of one of the TD vaccines throughout the presentation. And we will be utilizing brand names just for ease of presenting and not having to name multiple brand names for combo vaccines throughout the presentation. Our learning objectives today will be to discuss the updates to the CDC vaccine schedule and how they apply specifically to the pediatric patient population. We'll recognize the place in therapy and appropriate use of new single antigen and combination vaccines that are now on the market, and also recall best practices for IM injections in regards to site and injection volume for specific age groups.
We do have a few audience poll questions built in here. So you want to pull out your PSW app. If you actually click on this session, and then at the top, there is a polling section. It says polling right under the star rating. Just to see kind of who we're talking to here. So just looking to see what the primary practice setting is for those of you attending, whether it be the outpatient ambulatory, the inpatient with the PEDS unit, or other if you're a student or industry or whatever it may be. I'll give everyone a second to answer that. You should be able to see the answers right in the app there. So it looks like we have mostly someone with a inpatient setting with a pediatric or neonatal unit here, but also a good number of ambulatory care pharmacists. And then with regards to vaccines, trying to, again, judge people's involvement in this space as we talk through it, wanting to see how involved pharmacists are. So do we have pharmacists that are routinely giving vaccines? Do someone involved in ordering, in the coordination of the vaccines? Looks like we have a lot of otherwise a lot of people who are coordinating purchasing, compliance, and distribution. So I think that's perfect because we're going to talk a lot about vaccine compliance, distribution, and I think a lot of this goes to what should we be purchasing? Should we buy these new vaccines or should we kind of stay with what we've been doing before? So a lot of considerations around that. And then just wanting to point out that this is kind of a overarching list of brand names that we'll be using and their associated generic names throughout the presentation, just to basically serve this slide serves as a point of reference, and we'll also introduce the generic names on each slide as we talk through it. So the first thing I want to talk about is respiratory syncytial virus, very common cause of morbidity and mortality, both in the very young and the very old. And there's a lot of big updates that happened last year that impact both if you have a hospital with a neonatal care unit, or if you're in the ambulatory care setting, or you might interact, or the outpatient care setting, even you might interact with a pregnant woman looking to get the vaccine, wanting to talk through these two new products that we have. So first we want to talk about what did we have for prophylaxis of RSV before last year? Right, so going all the way back to 1996, we had Respigam, right? The IV immune globulin that we could give to very small babies, very high-risk infants that contracted RSV. Then just 2 years later, we got palivizumab. Some of you might not know about the brand name Synagis. And essentially that's all we got was palivizumab for 25 years, right? We didn't get anything new on the market. You can see one drug that you've probably never heard of that tried to get approval here was actually rather efficacious in the Southern Hemisphere, Mexico, Central America, but actually just never met those safety and efficacy findings in the US. So we get, our revision of palivizumab in 2014, which basically meant we were giving it to even less kids. It's a costly therapy. It can cost anywhere from $5,000 to $15,000 for a course just for one season for one infant. So we're only giving this to high-risk infants, right? So from 1998 through July of last year, right, 25 years, we had basically nothing new. It was just palivizumab every RSV season to the high-risk infants. And then all of a sudden, what happened? July 2023, FDA approves nirsevimab, this long-acting monoclonal antibody. They approve it as a vaccine, which is kind of odd, and I'll talk about that in a little bit. And notably, this is a vaccine for newborns, right? So really, when you think about newborn vaccines, right, you have the classic hepatitis B vaccine, right? And then you get nothing else until they're 2 months old. So it's not just a new vaccine, but a new vaccine for newborns. And then the very next month, we get the maternal vaccine for RSV. So now we went 25 years without anything new. And now in 2 months, we have 2 new agents. And if you notice the timing of this, and if you're familiar with the timing of the RSV season, right, this is July and August. We think about the RSV season starting usually in the Southern Hemisphere, maybe in October, and Wisconsin about November. So we're, 1 to 2 months away from RSV season. And now, surprise, there's 2 new agents, and how are we going to implement these? And maybe some of you had these same struggles. So if you're not familiar with nirsevimab, it is a monoclonal antibody, but it's approved as a vaccine, right? So it's just that passive immunization that you're getting from this monoclonal antibody versus the active immunization that we think about with your more traditional antigen-based vaccines. And so obviously, like I said, it was approved via the vaccination pathway, and then also got added to the CDC vaccination schedule chart. As you can see here, it's actually the very top thing, which is very weird to me as a pediatric practitioner, right? For the last however many decades, every time you pull up this chart, right, Hep B is the first line. Why nirsevimab is the first line, I'm not actually sure, because alphabetically it doesn't make sense, but it is. They put it at the top of the chart, marketing or something, I don't know. But right, so it's just very different to look at, but this monoclonal antibody now finds itself at the top of the pediatric immunization chart. So why are we moving away from palivizumab and to nirsevimab? So again, palivizumab was only for those high-risk infants, right? If you didn't work in a peds specialty center or an ambulatory clinic that saw a lot of high-risk pediatric patients, you may not be very familiar with this, right? And you think, well, I don't do anything with RSV prophylaxis in neonates, and maybe you didn't, but now, right, if you have primary care pediatrics or family medicine in your practice, nirsevimab is something that you are most likely to come into contact with now. Right, because we move from high-risk infants to all infants in their first RSV season. So that either means in the birth hospitalization, in that first visit or 2 right after discharge from birth hospitalization, or for those infants that are born over the summer, they're going to get caught at one of those primary care visits as they approach their first RSV season. Palivizumab, notoriously hard for compliance. This requires families with medically complex kids to get to a clinic every month for 5 months in a row to get an IM injection. Versus nirsevimab, we have 1 shot, we get at least 5 months of protection. Again, it's approved as a vaccine, which makes it eligible for VFC, the Vaccine for Children's program. So that's a program that provides free vaccines to certain populations, patients without insurance, patients with state or federal insurance like Medicare and Medicaid. So this has actually reinvigorated some interest in health systems using the VFC program because now they have so many more pediatric patients that might benefit from this VFC program with all infants being born eligible for this vaccine. And just to call it, now the number needed to treat, we really can't compare all infants to the high-risk group that got palivizumab, but I think this is pretty impressive. So the number needed to treat to prevent just 1 ER visit, right? So we're giving this nirsevimab to all these patients, right? Like, what's my efficacy, right? How many RSV infections am I actually presenting, right? So there's obviously the number needed to treat varies based on primary care, ER, inpatient. So I kind of pick the middle of the road being the ER. It's only 48, which for a drug like this, right, that you're giving a vaccine that you're giving to everyone, you're preventing one ER visit for every 48 doses of this vaccine you're giving. Like that's really impactful. If we extrapolate that out to births in the US last year, this is going to over the RSV season. So again, I think oftentimes we think about vaccines being boring or right, we're giving this like herd immunity, but these diseases are so rare now, right? How many patients that get any given vaccine are actually going to interact with say like someone that has polio, for example, right? Obviously the herd immunity is extremely important, but you may not actually be preventing that individual patient. And here I really feel like we're preventing that individual patient potentially from going to the ER. So we had this great new drug, and then if you look at the data on this, right, like 3 months after it was approved, we get slapped with, actually, you can't get it. Sorry. So this basically took us back to, well, now restrict nirsevimab for just your patients that are super high risk, like your palivizumab patients. So that was really frustrating. This went on for most of the time. Again, a lot of this was related to the FDA timing and the ability of the company to produce it after the FDA approval, because it was very short window between approval and RSV season. So this caused a lot of confusion, and maybe some of you guys dealt with that in your practices of, we have 10 doses of nirsevimab on hand, like who's going to get these 10 special doses, and how are you going to triage that? So we ran into that. Thankfully, we also had the maternal vaccine, right? So what I talked about before is a month after nirsevimab came out, we got the RSV pre-F vaccine, Abrysvo, from Pfizer's RSV vaccine. And that got approved for use in pregnant mothers. This rather narrow set of criteria that have to be met to give this vaccine, right? So you have a 4-week gestational age window to give it. It also needs to be given 14 days prior to birth so that the mom has time to get this antibody levels up and get that placental transfer of the antibodies. And it's only through between September and January. So all these things have to line up to give it. Again, thankfully, with the approval, we were able to get approved. You could order it and use it almost right away last year, given the timing. Interestingly, in Europe, and I'll talk about this more in a bit, it's actually approved down to either 24 or 26 weeks gestation now. We'll talk about why in a little bit. So I think the big question is, right, and as pharmacists, you get this question, especially from expecting mothers saying, should I get Abrysvo or should I wait, not get anything, and give my baby nirsevimab? So you don't get both, unless you're a very high-risk infant, which I'm largely going to avoid talking about during this talk. You get one or the other. So the mother has this decision point at 32 to 36 weeks gestation. Do I get Abrysvo? Do I get nirsevimab? What is going to protect my baby the most? And looking at this slide, you may say, well, nirsevimab is 80% effective, right? Like, why would I ever give Abrysvo? And you can't take that at face value. Actually, COVID plays into this. The study for Abrysvo kept giving the RSV pre-F vaccine, even when there's no RSV. If you guys remember, there was a weird viral surge in the summer. So, and there was essentially no RSV to be prevented in the winter because we were all masked and everyone was social distancing. Kids weren't getting the normal illnesses that they got. So this study, the Abrysvo vaccine, just kept giving it through the whole thing because they didn't know when the RSV season was going to come back. Versus nirsevimab, they waited until there started to be an RSV spike and then they started giving it to these babies. Right, so they kind of had this targeted study versus the Abrysvo couldn't. So all in all, the CDC doesn't actually recommend one over the other. They say either is fine, either is appropriate, either gives you adequate protection. That said, they do recommend Abrysvo for all pregnant females. But knowing that this nirsevimab is available, it definitely becomes that decision point. So I think pharmacists having that understanding of that efficacy and like why this looks so different is important. Also, when we think about vaccine myths, right? So why is it only 32 to 36 weeks gestation that you can get this, right? So we need that 14 days before birth, which makes sense, right? So there's a lot of babies born to 38 weeks is now considered term. So we want it 14 days before birth, but also we were worried about preterm birth. So there are other RSV vaccines that did not get approved that showed higher incidences of preterm birth. However, this medication did not. And actually, those ones only showed higher incidence of preterm birth in low-income countries. There was no difference in the middle and upper income countries. And then, so right? The FDA knows that. And so Abrysvo comes along and they do their study. And there's not even a trend, maybe what you would call a suggestion towards maybe a few more preterm births in low-income countries. Again, absolutely no change in high-income countries like the US, Europe, Canada. Again, not statistically significant at all. But because of that history, the FDA says, we're only going to allow 32 to 36 weeks because we don't want to risk any preterm birth. Now in Europe, like I said, they looked at it and said, we're Europe, we're a high-income European Union. We are going to approve this for down to 24, 26 weeks because there is no data that actually suggests any preterm birth. So again, this is one of those data points where I think we have to worry about, are people going to get scared off to getting Abrysvo because of this? I also think in the future, we'll likely get some data that out of Europe, because they're going to give it to patients in 26 weeks gestation, right? In a year or two, we're going to have all this data out of Europe that really definitively says yes or no as we get those post-marketing results back in. Nirsevimab, again, I think the concerns are the supply and the access. I believe that that's going to be really good this year. The manufacturers had a whole year to basically stockpile warehouses, allow pre-orders. So I don't think access is going to be what it was last year. I don't think we'll see another CDC alert. Hopefully we don't. And then there's the delayed onset. So the delayed onset, right after you give the IM injection, it's about a week. So it's nothing crazy, but at the same time, the younger you are, the more high risk you are. So you are susceptible to RSV for that week after you get Nirsevimab before it gets to that peak of efficacy, versus if the mother gets Abrysvo, those antibodies are circulating from the moment the baby's born. So some pearls for your practice. Obviously, error proofing, especially if you're in an outpatient setting where you might carry both, right? You might have Abrysvo and then the RSV vaccine that's only indicated for the older adults, RXV, right? They both start with A, somewhat similar looking names, they both have a Y in them, right? Like there's a look-alike, sound-alike concern here, right? So what are you going to do at your pharmacy to make sure that you don't confuse these two and accidentally give the RXV vaccine to a pregnant female? If you do, obviously the CDC would be interested. There's not a cause for concern or running to the ER, but it definitely is something that needs medical follow-up, and the appropriate people should be informed of the error. We also have to talk about the mother's expected immune response, right? If mother is on chronic steroids or on some other immunosuppressant, right? Maybe mom had an organ transplant or has some other disease that requires chronic immunosuppression where she's not going to mount that antibody response, right? There's nothing to say that the mom can't get Abrysvo, right? But the counseling point needs to be that your baby is likely will still qualify for Nirsevimab. So this is actually an incident where the mom can get Abrysvo and the baby can get Nirsevimab. And maybe just making the mother aware of that, right? Do you still want this vaccine, even though you are unlikely to mount this immune response? And then future pregnancies. So this is actually really weird. I think it's weird, and maybe it'll change in the future. And it's not a now problem, but probably maybe a next year problem as we get further out with Abrysvo being on the market. Right, we think about other vaccines in pregnancy, either you get them once or every time. So this one, the recommendation, obviously, your first time you get pregnant or the first time you get pregnant with Abrysvo available, you should get Abrysvo, and that will protect your infant. Your subsequent pregnancy, the CDC recommendation is actually do not get Abrysvo, just give the baby Nirsevimab. So kind of a weird recommendation, right? As far as, it's kind of weird for the CDC to say, we don't want you to do this. And now a lot of that goes back to the OS study, right? It was never studied in subsequent pregnancies. So there's just no data. So it's possible this changes in the future. But the current recommendation is that only you get it for one pregnancy. And then after that, you have to go to Nirsevimab. So as we think about, again, next year, how are you going to screen for patients that, again, it's between September and July, and they're between 32 and 36 weeks, and they haven't gotten this before, and they're going to mount an immune response, then give Abrysvo. Right? So there's a lot of screening and a lot of, I think, pharmacy steps here. It's not just as simple as, oh, you're pregnant, here's your vaccine, right? We need to be more thoughtful as practitioners. And the last pearls I'll leave you for are with Nirsevimab. So again, kind of we talked about that slide, the safety and efficacy, right? Do you understand, are you able to talk to a mother and say, here's the benefits of Nirsevimab, here's the benefits of Abrysvo, which one is maybe in the best interest or in the preference for that mother. Again, so will we still see some palivizumab for these high-risk infants in their second year? I didn't even talk about them too much, but in those in the palivizumab era, we were able to give prophylaxis to these kids up to 2 years of age. The cutoff for nirsevimab is 19 months of age. So after that, you cannot give nirsevimab. So if you have this high-risk kid who didn't get into clinic before the start of the RSV season, and now he's 20, 21 months old, do they get a dose or two of palivizumab, or will insurance pay for it? And I don't know if we know that answer right now, but by and large, we really shouldn't see much palivizumab use this year and moving forward. How are you going to communicate this, right? So if you're a birth center and you don't have a NICU, or you transfer a lot of babies out to a higher level NICU, or you have a NICU that receives transfer in, how are you going to get that information about the mother, and how are you going to communicate that to the NICU? Right? Because they need to know, when did mom get the vaccine and when did she give birth? Right? It's not just simply, did she get vaccine? Yes, no, right? You need that date. So what's your plan with those NICUs that you have contact with? How are you going to transfer that information? Timing, when can we start giving this? So I've talked mostly about infants that are getting it, right, maybe at birth, but for our infants that were born over the summer and they're coming in, when can I start giving this? So if you see the highlighted wording, it's a little kind of wishy-washy, right? There's not a date there, it's just shortly before. So in general, October 1st seems to be a good answer, especially in Wisconsin. We know it hits a little harder in the beginning of November. But if you have a family, say in an outpatient clinic, and you're like, there is no chance this child is going to see a healthcare provider, and it's July, you can give nirsevimab. There's nothing preventing you from doing that, right? So the younger they are, the higher risk they are. So you'd rather prevent RSV in this infant when they're 4, 5, and 6 months of age, and say, okay, now you probably don't have much protection for the latter half of this RSV season, but that's okay because your risk is substantially lower just because you're older. So it's really about getting these shots into these kids whenever we can. Payment was a big issue, and I'm not going to spend too much time on it, but obviously if we're getting this in the birth admission, we would then need the reimbursement for the birth hospitalization to increase. There was a lot of issues with that last year, just because, again, the timing of the approval and inpatient versus outpatient is going to be very center specific. So just knowing your center's plan, and are you doing this more on the inpatient side or more on the outpatient side? And then again, that supply, which I feel pretty confident in saying the supply is going to be good this year. And just knowing that there's been pre-orders and that the company's had a year, but again, I think there is that shock of last year of, hey, we got this great drug, actually just kidding, you can't have it, and none of it exists. And with that, I'm going to pass it over to Kayla to talk about pneumococcal.
All right, so we're going to transition to something that you guys are probably a little bit more familiar with. And that would be first the updates to the pneumococcal vaccine. So for those of you who haven't heard, PCV 13 is out, and PCV 15 and 20 are now the recommended pneumococcal vaccines recommended for the pediatric schedule and for the catch-up schedule. So there is no longer PCV 13 being manufactured. It was removed from the CDC recommendations. And so if you still have supply of PCV 13, it is no longer reimbursable. So you go ahead and remove that from your supply and move towards the PCV 15 or the PCV 20. PCV 15 came out in 2022, and PCV 20 was verified in 2023. And they are both recommended equally for the recommended childhood immunization series. This series starts in the second month immunization and then is given every 2 months for 3 doses. And then the 4th dose is given between 12 and 15 months of age. There are also additional booster doses recommended for kids who have special situations between the ages of 2 and 18. And the CDC also updated in 2024 some additional special situations for some of these pediatric patients that were not previously mentioned on this list. So in the orange, we have highlighted the new recommendations for chronic kidney disease. So these are patients not being dialyzed currently. They can now receive booster doses. Chronic liver disease, and then also a big patient population that we have to start thinking about in our center is the moderate to severe persistent asthmatic patients who can now receive PCV vaccines, which they previously were not able to. For brevity, I won't go through the immunocompromised conditions. That is also a second list. There were no updates to that list in the 2024. So for those of you who do provide these booster doses, either in your center or in the community setting, there is a long schedule on how to provide these and if-then situations. The CDC also has an app that you can utilize on previous doses received and when to give the next dose and which version of the next dose to give. For just a general overview of things to consider on if a patient needs to receive the PCV20 or not, we think of our patients in two separate categories. So those special considerations and the immunocompromising conditions. Really, the CDC focuses on if they've received the PCV20 or if they only received the PCV13 in previous doses. If they have received a PCV20 in the past, then that directs one pathway to administer booster doses in these special situations. And if they have not, they may receive an additional dose of PCV20 before receiving additional doses of boosters. And then there are separate schedules provided by the CDC for the 2 to 5 year old age group, and then also the 6 to 18 year old age group. Way too complicated for me to put up on a screen and read through. It's all available for your reference through the CDC website. But the big question is for patients who already completed their routine schedule with the PCV13 vaccines, should they also be receiving the PCV20 vaccine? And the answer from the CDC is no, that no further doses of the PCV20 would be recommended at this time. And those patients would proceed with the standard recommendations if they're an otherwise healthy child. They'd receive the pneumococcal polysaccharide vaccine 23 when they reach that 65-year-old age cutoff. Also, in preparation for this topic, we realized that in June, the PCV21 was recently approved by the FDA. So this added a question of, is this something we need to consider in our pediatric patients? And it was only approved for the adult population. So the question is, why is this for adults and PCV20 is being recommended for pediatrics? There were 11 new serotype coverage provided by the PCV21 that were previously not covered, meaning that the pneumococcal diseases that our pediatric patients are catching and exposed to are a lot different than what the adult patients are being exposed to. And so it actually removes coverage of 9 serotypes currently covered through the 13 and 15 vaccines, and it removes serotype coverage of 10 of the previously covered in the PCV20. And so with those introduction of the new serotypes, this is really an adult-specific vaccine. We don't really foresee this being labeled or updated for pediatrics, but possibly 10 or 15 years down the line, when those are the serotypes we start seeing more frequently in pediatrics, like a lot of other disease states, this is something we may see introduced into pediatrics, but right now it's pretty specifically just for adults. If you go to the pneumococcal vaccine recommendation, there is kind of a banner across the top still recommending that the CDC will be updating those more specific guidelines on previous PCV doses administered to adults. It's still pending as of yesterday. And now moving on to our tetanus updates from the CDC. The tetanus updates really revolves around the manufactured products that are non-pertussis containing. So in 2022, the diphtheria and tetanus toxoids, or the DT vaccine, was no longer manufactured by Sanofi. There were no CDC recommendations to stop giving this vaccine, so a lot of pharmacies still had supply circulating that supposedly expired well into 2023. So again, if you have a DT vaccine in your fridge, make sure you're checking those expiration dates, because at this point they're likely expired. The caveat with this is DT was the only non-pertussis containing tetanus toxoid indicated for use in patients less than 7 years old. This is kind of a small pediatric population that I'll talk about in the next slide on who this impacts the most. So what is available? There still seems to be a lot of available supply of the DTaP, the Tdap, and the TD. However, we were warned by the CDC that the TD vaccines were anticipated to have some supply restrictions due to the also manufacturing practices of the other TD vaccine. So Sanofi is still kind of producing the TD through Tenevac, and that was expected to augment supply of this removal of the DT from the market. However, the TD Vax from Mass Biologics was concurrently discontinued. So for those of you who are using just the TD without the pertussis component, it's something we don't routinely stock in our supply, so I'm not sure if that has been affected for those of you who do supply this. So for patients who should receive the TD vaccine because of the restricted supply, the CDC recommends only using the TD vaccine for patients who are greater than 7 years old who have a true pertussis vaccine contraindication. The contraindication would be defined as anaphylaxis to a previous pertussis-containing vaccine, and then also encephalopathy within 7 days of administration of that pertussis-containing vaccine as well. Family history is not considered an adequate reason to withhold a pertussis-containing vaccine. And so the recommendation is to give the first dose of a series with the DTaP. And if the patient then has a contraindication to receive, then you can proceed without giving a pertussis component in future doses. So for patients with a true pertussis contraindication who are less than 7 years old, this presents with a little bit of a dilemma for us. The Tdap and the DTaP are readily available currently. Like I said before, the Tdap is approved for ages 7 and older, and the DTaP is approved for patients who are less than 7 years old. And those are now the recommended products for us to use for wound prophylaxis when we're giving those doses kind of in between those booster doses. Just for a reminder, the CDC wound prophylaxis recommendations are listed above. So we first start with knowing how many doses of the tetanus vaccine that the patient has received. And then also if there's a clean or minor wound present versus a dirty wound, which we would say like in our emergency department. And using those recommendations, we would administer either the DTaP or the Tdap in our care setting. So the CDC recognizes that there's no longer a non-pertussis tetanus product now for patients less than 7 years old. And so they do recommend the off-label use of the TD product in place of the DTaP for patients who are less than 7 years old, at any age less than 7 years old, if they have that true contraindication. There was also a recent study that confirmed these findings. The WHO published an expert consensus group that TD does yield durable immunity when given in place of the other pertussis containing components with that lower diphtheria component in booster doses given between 4 and 7 years old. So the focus of this study was starting at the age of 4. So it's a little bit different than what the CDC recommends, that you can give it technically less than age of 4 if needed. They found that there was enough lasting immune response of that diphtheria component and the tetanus component when given at those routine booster intervals. So they tested 5-year intervals, 10-year intervals, and then also an 11-year interval. And they found that there was lasting immune response when using either of the vaccines. 10 countries surprisingly already follow this practice of using these products interchangeably in younger age groups. So the United Kingdom utilizes the Tdap IPV and the DTaP IPV for patients starting at the age of 3¼ years old. And then Italy also utilizes the Tdap starting at 5 to 6 years of age. So this is something, there's questionable reimbursement and questions as far as how sound this is and how often it's actually being given. But if you are in a pinch and you have a patient who has a true contraindication, you can consider using the TD product for a young pediatric patient. So this brings us to our first learning assessment question. Which of the following is not an updated recommendation according to the CDC routine immunization schedule? A, if a mother receives the RSV vaccine within 14 days of delivery, the infant should still receive nirsevimab. B, PCV13 should no longer be used to complete the pneumococcal series for a catch-up schedule. C, nirsevimab is more effective than the RSV pre-F vaccine and is the recommended RSV prophylaxis for infants entering in their first RSV season. Or D, the TD vaccine may be considered for wound prophylaxis in patients less than 7 years old who have had anaphylaxis to a pertussis-containing vaccine in the past. Thoughts? Any ideas? Think of it in your mind. All right, so the answer would be C, nirsevimab is more effective. There have currently been no head-to-head trials to compare. Hopefully after this season, we'll have more evidence to support which of the vaccines we should be giving, either the maternal or nirsevimab to babies. Otherwise, A, B, and D are all current recommendations by the CDC.
I'm gonna switch it up and go from, I guess, infant vaccines, we're talking about RSV, to some newer combination vaccines that hit both the infant and the older population. The first one I'm going to talk about is diphtheria and tetanus toxoids and acellular pertussis inactivated polio, Haemophilus B conjugate, and hepatitis B vaccine, which is a mouthful, right? And that's because it is a hexavalent vaccine. It's the first hexavalent vaccine, right? So 6 different antigens all in a 1/2 ml vaccine, right? So you can see all 6 highlighted there in different colors. Brand name for this is Vaxelis. right? And so this is FDA approved in 2018. Why am I talking about it in the presentation in 2024? So it was approved in 2018, but for some reasons that you guys can probably come up with on your own, there was a delayed US market rollout. Didn't really hit the US market until later in 2021. Really started to get use in the last 2 years, year and a half or so. So wanted to bring it forward here that it is approved as this 3-dose series from 6 weeks to 4 years of age. And it does save a poke compared to our current combo vaccines. Kayla will talk about the concern about muscle volume, especially when we get into the winter months. But just to call out what we have here, you can see Vaxelis on the bottom row there. Right, so you can see we have various combinations of things that cover anywhere from 4 to 5 different antigens. I know Pediatric is a highly used vaccine that we see in the infant population, right? But nothing gave you everything, right? Pentacell was about as close as we got, but you still needed that extra Hep B shot. So Vaxelis got them all into one single IM injection. So really great. But there are some pearls that we need to think about when we're using Vaxelis. You can see the green stars there on the left, just highlighting what antigens are in Vaxelis. So you can see really for this infant, 0 to 12 months, 0 through 9 month vaccine schedule, Vaxelis is really giving us everything we need to inject other than pneumococcal, right? Reminder that rotavirus is an oral vaccine. So the first thing I want to call about is kind of right, the space here. So if we give Vaxelis at 2 months, 4 months, and 6 months, plus we know that all infants get that birth Hep B shot that we're also familiar with, you get a 4-dose series of Hep B. And the CDC says that is perfectly fine. We don't need to worry about that. And if you're using Pediatric, you're already doing this. If you're giving 3 Pediatric doses at 2, 4, and 6 months, then plus that birth Hep B, right? You're already doing this. So that's not a concern. The other thing we have to be concerned about is that and be aware of. So this vaccine is approved for 2 to 4 years. However, if you look at that 15-month-old vaccination schedule, right? All these are essentially indicated again, but you cannot use Vaxelis for this booster dose. So Vaxelis is not indicated for this Haemophilus B booster dose. Of note, that's not currently in the package insert, but it is on the CDC website. So a potential pitfall there where someone could say, hey, it looks like all these are indicated. The CDC says as long as the other components of a combination vaccine are indicated, I can use, an extra dose of Hep B is not going to hurt anyone. But you specifically cannot use Vaxelis for this booster dose at 12 to 15 months of age. So that's an important thing to know if you're going to incorporate this into your family medicine clinic or to your outpatient clinics. So again, a little teaser to what Kayla's going to talk about shortly. But we do have concerns about muscle volumes in these kids because we keep adding more and more vaccines on, but right, the muscle volume, and not something we actually think about in the adult world, but the muscle volume of a pediatric patient is rather limited, especially in the first year of life. So you think about your 6-month-old infant entering their first RSV and flu season, right? So maybe someone that was born in April, May, right? They didn't get nirsevimab as a baby, right? They're going to be due for it now. They're going to be due for their first round of flu shots. So we need our standard vaccines, right? So Vaxelis plus pneumococcal, that's at least 1 ml. For not using Vaxelis, we're looking at probably 1.5 mLs to do the standard vaccines. Plus we need flu. We need your 0.5 ml flu dose and a second one 4 weeks later. And there's the COVID vaccine. And nirsevimab, which is a giant IM injection for a P, right? It's a 1 ml versus most of these vaccines are 0.5 ml, right? Nirsevimab is a big injection. Where are you going to put all these? Can you get them all in on the same day? Are you going to use the buttocks? Most nurses in peds vaccines, typically we use the thigh, right? That's the classic pediatric site for vaccine and IM injections. It's that vastus lateralis. Are your nurses trained to use the buttocks? Are you going to choose to do that? There are some risks associated with that. Are you going to prioritize nirsevimab administration, or are you going to prioritize the standard vaccines, right? You need a system strategy, right? Pharmacy should be involved in determining, maybe an ID specialist also, like, what are you going to do? So we've actually said we're going to do the standard vaccines plus the first flu. And when they come back for their second flu shot, that's when they're going to get nirsevimab. As a way to not fall off and have this kind of a hodgepodge mess of, well, this patient was following this plan, but this patient we gave nirsevimab to, and we deferred, the extra Hep B that we still need. right? So how do we make sure that these patients don't miss standard vaccines because they're trying to get the new and fancy vaccines that we just got into these kids? So you really do need some kind of system plan if you're in a position where you're vaccinating kids of this age. Next, right, I'll finally talk about something that's not under the age of 1. We'll talk about meningococcal vaccines, so maybe especially if you work in an outpatient area or an ambulatory clinic that sees mostly adults or teenagers, something more applicable to you. So if we remember, the meningococcal ACWY, right, has been added to the CDC schedule. It's indicated for everyone, right? So then kind of the shift to focus became on meningococcal B. And meningococcal B is still not indicated for everyone. It's that increased risk, right? That I think the classic thing everyone thinks about is that kid going off to college, right? There's a list that's available on the CDC website for sake of time. I'm not going to go through it, but the CDC talks about shared clinical decision making in patients who might be in a high risk situation for meningococcal B infections. So really any situation where that older teenage patient is going to be in close living quarters with a lot of other people. And an important part of understanding the meningococcal vaccines, not just that the ACWI is everyone and the Men-B is only certain patients, is that the ACWI vaccines are interchangeable, but the Men-B vaccines are not interchangeable. So historically, we've had Bexsero and Trumemba as 2 not interchangeable, but equally efficacious Men-B vaccines. So first I'm going to talk through the ACWI changes. So prior to 2022, we had Menactra and Menveo, very similar names. Again, these are interchangeable vaccines. However, in 2022, we got rid of the Menactra vaccine, and it actually got replaced by a vaccine called Menquad-Phe. Again, these are still interchangeable vaccines. It was approved in 2020, again, kind of had that slower rollout due to the COVID-19 pandemic. So now what's out there, right? So now we have Menveo and Menquad-Phe. Of note, right, if you're immunizing pediatric patients in, say, a family medicine clinic, you still might need to stock that 2-vial Menveo, even though that 1 vial just recently got approved in 2022, and it seems so much more convenient for those high-risk pediatric patients because they don't have that approval under 10 years of age yet with that. But then we have Menquad-Phe and then Trumemba and Bexsero. Those still exist. And those have been around for a long time. So what else changed? So then we also got this big combo vaccine. So I talked about hexavalent vaccine. Now we're going to go to a pentavalent ABCWY meningococcal vaccine known as Pembrea. So this just got approved less than a year ago, October 2023, rolling out now. So this is essentially just a combination of Trumemba and Menquad-Phe. Now remember, right, ACWIs are interchangeable, these are not. So now you have basically this, right, hidden, if you will, Trumemba in this Pembrea product. And right, how are you going to educate your patients and keep it straight? Right? Who got what Men-B vaccine, and when they're due for their next dose, right, you need a way to track either within your system or within your outpatient pharmacy. So Pembrea has that same indication as the others do, 10 years of age and greater. And you can give it when you need all serogroups on the same day. Right, so this might be your older teenager that got their first dose of the Men ACWI when they were in that 11 to 12 range. And now they're coming back when they're 16 or 17, right? They're about to go off to college and they say, hey, I need to start this Men-B vaccine series, but I also need my second dose of Men ACWI to complete my primary required series, right? So this is where Pembrea can come in. But we do have to be cognizant, again, Bexsero, Trumemba, they need to know that their next dose of Men-B has to be Trumemba. It can't be Bexsero. Otherwise, you need to actually give extra injections. Now, to take a step back, since we talked about Menactra being discontinued, again, those are interchangeable vaccines. And so you can use either of the ACWIs to complete that if you do have a patient that got their first dose with Menactra. And I'm sure we'll see this in the next few years here, where you have 4 or 5 years later, someone coming back for that second dose of meningococcal ACWI, and you see Menactra, you can give either Menveo or Menquad-Phe. So why I say Bexsero Trumemba health systems is, right, if you're a Bexsero health, right, if your preferred formulary agent is Bexsero, or the the local clinic or the local health system or where your pharmacy is near is Bexsero based, it may not make sense for you to carry a lot of Pembrea or any at all, right? Because you don't want to have someone get Bexsero and then come to you and get Pembrea, or vice versa. You get Pembrea and then they go somewhere, they go to this health system and they get Bexsero, right? So that coordination is really important. So we actually decided at Children's Wisconsin not to add it because we prefer Bexsero. And part of that goes back to the speed of vaccination. So with Pembrea plus another dose of Trumemba, those are 6 months apart. And then you are considered, obviously, to have the immunity to Men-B. However, Bexsero, right, we don't get a fancy combo vaccine, but we can do 2 doses 1 month apart, and that's it. So if you think about, right, your patient going off to college, right, especially if they maybe decide late that they want to, attend a college, or, some other life change happens where now they need to be immunized with Men-B, you can do 2 doses within a month with Bexsero, but again, if you use the Pembrea Trumemba, that's a 6-month gap. So where are they going to get that second dose if you're going that route? So just other things to think about, right? There's more to think about than just, oh, this is a cool combo vaccine, great, let's start using it, right? You have to be a little more thoughtful about what Men-B vaccines your patients are already either getting or have access to through the local health systems. That brings us to our second knowledge check. So if we have a 16-year-old male without a significant past medical history, and they're due for their second dose of their Men-B vaccine today, they got their first dose with Pembrea. And when they got that Pembrea, they also completed the patient's primary series of their meningococcal AC and WI, right? So both were indicated on that day. This patient's now coming back to you and wanting to finish off their Men-B series. So what are the options here? So you can think about it in your head. Right. So Trumemba is really your only option here, right? So Pembrea is not indicated because it's only indicated if you need all those serotypes on the same day, which here we don't need. We can't do Bexsero, those are not interchangeable. Again, Pembrea is a combination vaccine, and the Men-B inside of it is Trumemba. And then again, also eliminate C because again, they are not interchangeable vaccines. Just remember on the schedule, what we might see, right? So it's that 16, 17-year-old coming back in for that second dose, where they would need, again, the combo vaccine with the Men-B and the ACWI, and then coming back in for that second Men-B shot. I'll hand it back over to Kayla, and we'll talk about some volume and site concerns with intramuscular injections.
So we thought it'd be pertinent to discuss our intramuscular injection practices from Children's Wisconsin because there are some standardized practices available out on the World Wide Web and others are harder to find. So IM injections, as you can gather from what Jesse and I have presented already, are very commonly used in the pediatric patient care setting, most commonly through vaccinations, routine vaccinations. So we're giving IM injections all the time throughout childhood, often using multiple sites, multiple IM routes, in one visit. We also utilize the IM route as an alternative site for instead of utilizing an IV or placing a peripheral IV in an urgent care emergency department setting. And that comes back to the complications and risks that we have to consider with IV placements in pediatrics in those short-term care settings. IVs in pediatrics can require increased time and skill, nursing specialization to place them. One study observed that it took nurses, even with specialization of that skill, it took up to 30 minutes to place a PIV in a pediatric patient. So sometimes it's just faster to use an IM route. Placing a PIV can be traumatizing. So for any of you who have kids or you've observed this process, seeing a needle go into your skin is not fun for anyone. So it can be traumatizing, especially for our complex care kids who come for frequent visits. Receiving IV medications can be one of the traumatizing factors of that visit. Infiltration is very, very high occurrence in our neonatal patients, especially. You think of how small their veins are and kind of the osmolarity or the viscosity of some of those medications that we're infusing. We lose IVs all the time because of the infiltration risk associated. And then we also have similar risks to adults with occlusions with the hypercoagulation state of a patient when they're sick. And then also PIVs are very easily lost. Kids see the site, they want to pull it out. They're running around the room, even though they may seem sick, they're very resilient. So we have something stuck into their arm. We have ways to try and keep it fixed, but we lose these sites all the time. And so utilizing the IM route is oftentimes an easy way to kind of get around a kid who lost a PIV in the middle of the night. We can give the medication through the IM route, and this helps not skip doses and continue with the care that the patients need. So we have established some standardized IM injection practices. There are some recommendations from the CDC that are standardly referenced on needle lengths and gauge sizes, as well as which IM sites to use when giving medications to pediatrics. However, we found that what isn't as readily available are those maximum volumes into those muscle sites. So in the last couple of years, we observed at our own institution that we had several references for several different care our different colleagues. So our nursing colleagues had one reference, our pharmacy seemed to use one reference. So we collaborated with our interprofessional colleagues to create a more standardized single reference to use at our site, utilizing a very in-depth lit search. We utilized some resources from MCW's librarians, because when we looked for evidence to support maximum volumes in muscles, we just really couldn't find good information that was consistent across the board. And this really comes back to that intervariability between pharmacists making decisions or nurses making decisions, having to think about when we give too much volume to a patient, we can potentially adjust the kinetics of that medication, of a larger volume being put into a small space, which can also increase pain of that injection. And then when we try to minimize volume due to the pain or due to the kinetics, we also find that we have to split the volume up, which also leads to more injections and more pain. So we really have to find the balance of where are we maximizing our volume so we can limit the number of injections, but also not compromising the kinetics of the medication itself. So I'm going to show you just some pictures of what our institutional guideline looks like. And if this is something you don't have as a resource at your own institution, I would definitely recommend getting a group of people together to come up with something similar, because it has been a really good asset to our care settings like in urgent care and the emergency department. So we first split up the maximum volumes and needle length by age. So you can see our common ages listed here. There's a picture listed, so for our nursing colleagues who are maybe newer or haven't utilized that muscle site before or as frequently to give an injection, gives that reference visually for them. We list the maximum fluid volume per muscle, and this is also where we highlight which sites are recommended for each patient. And then also needle length is recommended and commonly referred to in other references. And for this presentation, I won't be going into specific needle length in the following slides. So what sites do we use for which patients? The first site we would use most commonly is the deltoid, as I'm sure most of you, this is how you were trained to give an IM injection in that upper shoulder muscle. We do not recommend this site for patients less than 1 year of age just because of the size. But for patients who are 1 to less than 3 years old, we can use this if that's an additional site needed, like Jesse was talking about before. If you're giving 5 or 6 different vaccines on a visit, we can utilize the deltoid, but we only use up to 0.5 to 1 ml per muscle, usually limiting it to 1 injection. For our patients older than the age of 3, this is our preferred site at our hospital. 3 to 10 years old, we can give up to 1 ml per muscle, and greater than or equal to 11 years old, we can give 2 mLs per muscle. So sometimes this allows for several injections in that same muscle as well, considering the size of the patient that you're giving those injections to. Some pros and cons is that it is easily accessible, especially in a community setting. You can just have the patient lift their sleeve up. It's quick, it's easy to get to. However, we are limited in the volume that we can administer in this site. So our other main site of use is the vastus lateralis, like Jesse was talking about before, that upper thigh muscle. So this is going to be our preferred site for patients who are less than the age of 1, also for patients who are not yet walking. So you can see our maximum volumes listed. 0 to 28 days, we give up to 0.5 ml per muscle. 28 days to 1 year old, we give 1 ml per muscle. 1 to less than 3, we go up to 1.5. And then 3 to 10 and greater than 11 years old, we can utilize this site if we need to. But we find with those older kids, we tend to only use these if that extra site is needed. Of note, other than vaccines, this is the preferred site for all anaphylaxis medications. So if you're giving an EpiPen due to the vasculature of the vastus lateralis, this would be the recommended site regardless of age. So please don't try to give EpiPens in a deltoid, this because of the vasculature and how quickly you're able to get epinephrine to the patient. The vastus lateralis would be the recommended site. And we are able to give larger volumes. So that is a benefit of using the vastus lateralis. The ventrogluteal site is an option for administration. We don't commonly see it as much just because of our nurses' comfort in using this site and using this muscle. It's also a little trickier to get to when patients have clothing on or you're in a more clinic-based setting. But for our patients who are going to utilize that site, we do have max volumes recommended. 1 to 3 is 1.5 per muscle, 3 to 10, we go up to 2, and then greater than 11, we can use up to 3 mLs. This is across literature the most reported as the least painful site. So if that kind of allows you to give a injection in a patient who otherwise needs reason to, not get an iron injection, this could be something you tell them that this tends to be the least painful option. Also for older patients or adults who are administering IM injections at home, this tends to be the easiest for self-administration of medications. And then our dorsal gluteal site, or that upper buttocks area, we do not recommend this ever for patients who are less than 3 years of age. And when it's used in our older patients, we really try to limit it to single injections or injections that have higher viscosity because of all of the risk associated with using the dorsal gluteal site. So we can give much higher volumes, 3 to 10, we go up to 3 mLs, and then greater than 11 years old, we give up to 4 mLs per muscle. It does allow for the largest volume, like I said, so can limit a poke in something. However, we only ever use this if the child has already begun walking, and that's because of its close proximity to the sciatic nerve and other major blood vessels. So risk of damaging that sciatic nerve in a patient who isn't yet walking. Also, this muscle tends to be smaller than like the vastus lateralis in younger patients, and so that's also why we would prefer not using dorsal gluteal in our smallest patients. This also tends to be the most painful site, which is another reason why we try to avoid it if we can. So one other additional piece that we've included on our guideline is some general injection reminders, just reminding our nursing colleagues on how to administer IM injections in the specific site. We also reference other peripheral types of references within our own network. And then we also have this small caveat at the bottom. I know it's kind of hard to read, but we essentially talk about maximizing the volume per muscle dose recommended. And that this means sometimes we have to split the volume of the medication in order to use the preferred muscle site. So one way we've automated this process at Children's Wisconsin is by utilizing in Epic our split syringe functionality. So in reference to the patient's age and the preferred muscle site, our orders will automatically split the volume into the max volume possible so that we aren't splitting unnecessarily a larger dose into 3 when it could be split into 2 doses. So this helps maintain consistency across our pharmacists who are verifying these doses, and then also helps eliminate confusion when maybe we want to push the boundaries on certain patients or utilize a different muscle group just because we weren't aware of what our preferences were. So this brings us to our last knowledge check. We have an 18-month-old, 10-kilogram male child who is not yet walking, requiring an IM ceftriaxone in the acute care site for acute otitis media. The volume of the IM injection is 1.4 mLs. So which administration site would be most appropriate for a single injection of the full volume of the ceftriaxone? Think about the answer you would come up with in your head. So we would recommend utilizing the vastus lateralis in this case. The deltoid site, we don't prefer to use in patients less than 3 years of age. And so this patient, also because of the volume of the medication, would have to receive 2 injections if utilizing the deltoid. The ventrogluteal is probably not going to be preferred by our nursing colleagues who are giving this, and our dorsal gluteal would not be recommended, although we could get the full volume and 1 injection. This patient's not yet walking, so there's some other risk factors with damaging those nerve and blood vessels. And so the vastus lateralis would be our preferred site where we could give that single injection.
I know we're right at time, so thanks for bearing with us for a second. We had those IS issues at the beginning, but just some takeaways here. Hopefully, no matter where you work, we were able to give you at least some pearl to think about, whether it be meningococcal vaccines, prophylaxis of tetanus, if you have a dirty wound come into your ER with a young patient, or if you have, that birth center and then your 7-MAP versus the new RSV vaccines. So just hoping that, we kind of covered a lot of the updates, and I think also just the fact of, right, when I learned about vaccines were boring and they don't change. But hopefully we've kind of, demonstrated, that they do change and they are changing, and there's a lot of rapid development right now. And that pharmacists need to be aware of it to safely use those new products. I know we're at time. So for questions, I think if anyone wants to find us afterwards, if anyone has maybe we can take one question. I also don't want to keep people here past the time. Thank you.